Thank you so much. It's really great to be here. I love Sydney. And I miss this university with all its quirks and bureaucracy and all those other things. I would like to pay my respects to the Gadigal people of the Eora Nation and pay my respects also to their to their leaders emerging, past, present, as well as to acknowledge that in Canada we are also all living and working on Indigenous land. The folks from British Columbia are on unceded land. The rest of the land is treaty land, which adds more of a complication than a solution often. All right, here we go. So you can all see the title of my paper. Let's move on to slide 2 already. So, though a substantial literature shows that criminalizing the use of non-pharmaceutical drugs does not lead to lowered use or improved health and social outcomes, criminalization has long been a strategy across most of the world, but definitely in Vancouver, Canada, where this study is based. Under intense pressure from activists and humanitarian groups to respond to escalating numbers of deaths from poison drug supply, largely illegal market fentanyl, the provincial government in British Columbia, so a province is like a state, so the provincial government in British Columbia, Canada, declared a public health emergency in 2016. Unobtrusively, they decriminalized the production and possession of small supplies of drugs. They also expanded the numbers of sites for testing illegal drugs to avoid further poisonings. They increased access to low barrier, inclusive, and supportive housing. Despite these measures, the deaths from opiate poisonings continue to skyrocket, precipitating calls for more extensive decriminalization and far-reaching low barrier supports. In this paper, we explore innovative policy and practice initiatives that emerged during this crisis and the impact of these policy and practice initiatives on older people who use drugs. The practices pivot around meeting people where they are, rather than demanding abstinence or rehab prior to providing services. The practices include decriminalization of street drugs, as I already mentioned, and the provision of a safe and regulated supply, as well as harm reduction and low barrier supportive housing for older people who use drugs and have a history of homelessness and trauma. This group of policies and practices stabilizes people's lives, lets them detach from the criminal gangs who control the illegal sale of drugs, supports health and well-being, and sometimes gets people to a place where they can address their trauma and addictions. In the meantime, these policies and practice recognize these folks as human beings who are deserving of respect and care. So given the harsh conditions of their lives, those who experience homelessness, trauma, and use drugs in Vancouver are considered to be old by the age of 45. So that puts me way, way over the hill. A growing population of older people who have current or past histories of drug use are in need of care and support services. In the 2023 Greater Vancouver Homelessness Count, it was reported that 22% of homeless people are aged 55 or older, which is a substantial leap from 2005 when they comprised only 10%. Like most jurisdictions in the global north, Vancouver has a policy of aging in place, or keeping people in their homes with more and more supports as they age. This policy has been applauded for providing self-determination and independence, but it's also been criticized for being classist and being underlaid by gendered assumptions that everyone has a home in which they are safe, comfortable, and wish to stay. People who use drugs and are or have been street entrenched have few options but to age in place in very challenging circumstances that do not promote well-being or longevity. Evidence suggests that even when they are accepted into nursing homes or other care facilities, they're 20 to 30 years younger than the other residents. They struggle with abstinence, and they find their life experiences leave them isolated. This may result in people leaving or being evicted from long-term care and once again becoming homeless. So in terms of the methods, and please ask me questions if you're a methods guru. So the data analyzed in this paper, the data are drawn from a much larger study of equity and aging in cities. We have an international team and we're descending on 12 cities worldwide, including Melbourne at the end of this month and Auckland just after that. Specific to this paper, we conducted 13 in-depth interviews with 3 large service organizations for older people who use drugs and have experienced homelessness. The focus of our larger study is older people and equity. So that included 5 managers or senior staff, 7 frontline staff, 1 service user. Interviews were semi-structured, blah, blah, blah. You can probably see all this stuff. And please ask me notes. Field notes were also taken and we analyzed the data together. So the strongest themes in the data include meeting people where they are, aging in place, and kind community. So let me move to the first theme. Meeting people where they are is a practice model that recognizes that some people will never stop using drugs or using other substances, but that does not mean that they should be abandoned or criminalized. Instead, their actions need to be seen through a lens of compassion and recognition that alcohol and drugs are means of coping with past and sometimes ongoing trauma. Meeting people where they are interweaves harm reduction and low barrier approaches to housing and health and social services. There is no demand for abstinence before care. Instead, practice focuses on meeting basic needs such as housing, food, medical, mental health, and social care. Specific needs are also met, such as access to safe supply of drugs, safe injection options and safer use, managed use, treatment options, etc. Reducing or removing barriers often involves allowing people to undertake practices that are not permitted in most social housing. For example, though I don't have the quote up there, smoking is permitted in all the facilities. And you can see some of the quotes here that capture the sense of how harm reduction works in, and low barrier meeting people where they are works in everyday practice. So the bottom line is they don't kick people out of housing. They argue that they specialize in assisting people who are street entrenched and supporting that community. There can be behavioral issues and there can be violence, but it's met with empathy and understanding. Let me move on to my next slide because I'm sure you can all read the quotes right there. Okay, so the next theme is aging in place. According to our research participants and Health Canada data, longer lifespan is largely attributed to better treatments for HIV. Everyone used to die from HIV, and good wraparound care is letting people live about 10 years longer than they otherwise would, according to our participants. However, a lack of supportive housing for older people who use drugs remains a serious problem. Like other populations, older people who use drugs tend to want to stay in the neighborhood where they've been living for 20 to 40 years. They know everyone, they feel comfortable and good in the space. We've got more medically based programs, which is super awesome. And I think that really allows people in the community to stay in the community and to continue to use drugs while getting the care they need. They are also able to access all their services, be in the community of people that they care about and things like that. I think it's the coolest thing, said one of our research participants. And my last thing, kind community. Though often vilified in the media and presented as violent and sociopathic, the research participants presented an affirming narrative of people who use drugs as contributing members of meaningful and caring communities. As one worker argued, there we go, this is obviously a very poverty-stricken, low-income community, but there is, when you work in the community and get to know the community, there is much respect and much compassion for each other. A manager told us that the people in the building in which she worked really take care of each other. We all take care, we have a positive environment, we work every day to create it and strengthen it, and people really respond. Rather than exploiting others, community members were presented as supportive to those needing more care As one manager told us, there's a kindness and generosity in the community. People really watch out for each other. And here's my last slide. So in terms of discussion and conclusions, beep, beep, I'm keeping it short. So these policies and practices emerged from years of intense activism on the part of people who use drugs and their allies. This underscores the importance of listening to the voices of service users and those with lived experience. Though I have to tell you, in this particular community, people rebel against the concept of a lived experience. They say everybody else gets to just have life experience, but we get this special thing called lived experience. It also shows that sometimes the acute pressures of crises can permit the emergence of new narratives, counter-hegemonies, and innovations in policy and practice. In part, this is because the stakes are high and the old solutions are discredited and unable to capture consensus on how to slow or end the crisis. And I'm going to cite Gramsci, just to have one moment of high theory here, because I love Gramsci. So Gramsci argues that rather than being linear and logical, social change is a choppy and unstable process with the kernels of new, more libertary social relations growing within the resistance and non-compliance of groups opposed to the current system. So the innovative policies and practices analyzed in this paper show the positive outcomes of long resistance on the part of community members and the blossoming of new, more socially compassionate possibilities for older people who use drugs. Regrettably, in Canada right now, we have leading right-wing politicians who are working to recriminalize poor people and their ways of coping with trauma. Hence, continued resistance and activism will be required to defend and expand these gains. In terms of recommendations, we argue that the lessons of this deeply compassionate model should be applied to other areas of social work practice and policy.
Love that. Love the call out to the discipline at the end. That's fantastic. And I love the intersectional nature of the research, dealing with areas of age and gender and class, and accessibility, educate, all those things, employment. It's just wonderful, again, to hear these narratives come through in the research as a part of creating that shared understanding across different spaces. Questions, comments?
Is everyone too weirded out?
Thank you so much, Donna. I guess one of the things about, because this was in Toronto, wasn't it?
Vancouver.
Oh, Vancouver as well, is that with the levels of homelessness that are quite high, and Toronto's even worse, isn't it? Yeah.
We don't really compete to be.
No. Are people actually living in the streets, or are there sufficient shelters for even, when it's really cold, for people to be off the streets? So, we see endless pictures of US cities with tents under all the freeways. Is it like that?
Yep.
Yeah.
Yep. And the neighborhood in which we conducted most of these interviews, it's a very poor neighborhood. It's called the poorest neighborhood in Canada, and there's regularly tent cities, and we unfortunately have a right-wing city council right now who decided to clear out the tents. And it's a terrible tragedy when that happens. And all that happens is for a brief period of time, the homeless folks are dispersed to other neighborhoods where there aren't services and supports. People, of course, die, and then they recongregate. Yeah, there was also this really interesting thing. They call it street sweeps or street cleaning, where the police just descend and clear everyone out. People had been cleared out of parks really frequently. And they said parks felt very unsafe. So they took up putting up tents on the sidewalk. And so the neighborhood, this very poor neighborhood, the main intersections were just covered with tents. And people said they felt safer on the sidewalk because there's traffic cameras and there's lights on all night. And because they face they face very high rates of crime and having their stuff ripped off all the time. So it was honestly a lot crazy, but it's very similar to, so it's the whole western seaboard of North America. Seattle, Portland, they all we all have the same problem with this toxic drug supply. Apparently we export to Sydney and Melbourne now. So that's great. No, no, that's bad.
Thanks, Professor Phillips. Other questions or comments? Yes, sir.
I'm just curious about like how the community how they build on like allowing the people to use the drug. How the community see this.
Oh, the community sees it?
Yeah.
Yeah, so most of the services that we studied, they're all in one community called the Downtown East Side. And it's got a very, very long history of activism and a very, very long history of drug use. So they fought for these policies. Like they're like the hotbed of activism on these policies. And these policies are studied all over Canada and the US and also Europe, because there's parts of Portugal that have similar policies. They have some policies somewhat similarly in Scotland, but they usually emerge from the communities themselves, saying like, we're not criminal. If we had safe drugs to use, we would use those. But because we don't, then we end up involved in criminal life. And if you think about other things like alcohol being regulated and legalized, or gambling, that takes it out of the hands of the crime gangs. People may still have addictions and struggle, but they're not poisoned by, some kind of homebrew alcohol anymore, and they're not in hock to the mafia because they gamble. So it's a similar argument. Like, we can regulate these things and we can make them safe so people aren't dying of dirty drugs, as they're called.
And last question, Mark.
And so you said that it came out of a public health emergency, was called in 2016. And I'm just interested in the politic of framing it as a public health emergency. We had a similar, I suppose, that was the Northern Territory of intervention by using sort of a framing in those ways of, now in this term, it was to introduce a different model of harm reduction, but I'm just wondering what the politic behind calling it a public health emergency was.
Yeah, good question. So that was part of the community activists' demand, was that the province take it seriously, because the deaths they're frightening. They're staggeringly high. There's at this point in time, there's roughly 7 deaths a day, which, over the course of a year is very frightening. So it was a demand, take it seriously. So they demanded for the public health emergency. It was, I think, the Howard government that declared that, and completely different politic. It was not to, to control and humiliate and paternalistically try to control people's lives. It's quite a different approach. In British Columbia, we have the only Labour government in Canada, and they're unlike many Labour governments in that they're not always disappointing. And so they did actually a very good job on this issue. And they're way out ahead of most of Canada in terms of the policy, but the deaths aren't slowing. And, there's demands to like bring in a regulated supply. But it's unknown how you would do that. It's not like, people regulating alcohol. People already had vineyards and people already had production. Like, you have to build production capacity to suddenly have a clean supply. And how do you do that? In all of Canada. Yeah, but that's different because they already had mass production.